welcome to this MedEClasses Grand Round on Primary Amenorrhea. And this is going to be a very interactive and interesting webinar in which we'll talk about 4 very interesting cases of girls who presented with amenorrhea and where we found to have a lot of issues in terms of assessment and diagnosis. We are really happy to have 2 of our colleagues who have joined from across the country. Dr. Sekhar is there, who is a practicing endocrinologist at Rajmundry, and he is working in the medical college. Dr. Sekhar, welcome on board. And,
good afternoon, sir.
Good afternoon. And he'll be presenting about a very, very interesting case. Then we have got Dr. Guru Prasad, who is part of the MedEClasses course and program as well. And he is practicing as an endocrinologist at Bangalore. Dr. Guru Prasad, welcome to the program. So we'll start off a bit with regards to the initial aspects of what is the common causes of primary amenorrhea, particularly with the angle of what we are discussing today about tall girls with amenorrhea. Then we will use those 4 cases to see how these practical assessment tips will help out. And all of these cases have quite unique issues which are there in terms of diagnosis and management, which we'll be covering from that perspective. So we'll start off first of all as to why it is important to evaluate for amenorrhea and what can be significant implications which can happen in that perspective. So I hope the slide is visible now. So this is a 17-year-old girl with primary amenorrhea who presented to us with stage 4 breast development and also a pubic hair development, and there was no menstrual cycle. So there was a normal development otherwise, but there was no periods basically. She was a tall girl. Now, this is a common concept which we'll talk about. All the 4 individuals we'll talk today were those who were either tall or had the potential to be tall, in that their bone ages were open and they had a delayed bone age in that perspective. It was found that the FSH level was high, LH was high, and estradiol was low. So our diagnosis was established basically of a hypergonadotropic hypogonadism and started on routine replacement therapy. Now, what happened on follow-up was a bit depressing, that the child actually developed a gonadoblastoma, and that was because a proper karyotype assessment was not done. And when we checked the karyotype, it was actually a XY phenotype. So it gives a big message that even if we have a classical feature of hypergonadotropic hypogonadism, we should look at karyotype. We have said that even if you have a child who looks entirely like Turner syndrome, even then karyotype is important because you may have a Y cell line. But if somebody is tall, then of course you want to talk about situations where you need to be very, very cautious in terms of assessment. So the theme today is about primary amenorrhea, particularly because of hypergonadotropic hypogonadism and tall individuals. So this basically brings us to a very narrow group, but a very important group of individuals who present to us with implications. Now, if we talk about primary amenorrhea, it's there around 2.5% of cases. Most of them would be physiological or functional in that perspective, but still there would be a significant number of pathology which we need to evaluate. Therefore, there is a need for meticulous evaluation in that perspective. You all can go and have a look at our website, learning.growsociety.in, where there are a lot of resources about pediatric endocrinology are available. Many of our courses are available in the form of fellowship and diploma programs, especially also for gynecologists as well as adolescent physicians. We routinely run 3 programs of PG lecture series and 2 grand rounds for the pediatric endocrinologist as well as pediatricians. And we have got publications which can be accessed both online as well as the hard copy, and our mobile application which helps making diagnosis very easy in that perspective. So the agenda for today is that we'll talk about 4 specific cases in a scenario where we have a girl who has amenorrhea with high estrogen. The second would be low estrogen and high androgen, an interesting case scenario. The third would be the issues with regards to whether there's a problem in the structure or the function, and then finally whether the gonad or the enzyme is defective. So these are 4 very interesting cases, all have common of having primary amenorrhea in a relatively tall girl with hypergonadotropic hypogonadism. So before we go that, we need to just have a touch base about pathophysiology of primary amenorrhea. So in that regard, we all know that there are 4 organs which are going to play a role: the hypothalamus pituitary as a unit, the ovaries, and the uterus. So all of them have to work in tandem to ensure that the periods happen. So we know that GnRH is a primary regulator of the gonadotrophins, which then synergistically add on the ovary. So LH acts on the LH receptor on theca cells to produce androstenedione, while FSH acts on the follicular, the granulosa cell, largely to produce aromatase, to produce estradiol. Now, both of them are synergistically required. What's important to understand is that in boys, LH is more important as compared to FSH. In girls, FSH is more important than LH. So abnormalities, isolated abnormalities in FSH or FSH receptor will cause a complete delayed puberty, no development, and primary amenorrhea, because you will have nothing, no follicle, nothing will develop. But abnormalities in the LH pathway, isolated LH defects, or if you have a LH resistance, will not cause primary amenorrhea. They will produce more like anovulatory findings in that perspective. If you put in the opposite perspective in boys, if you talk about abnormalities which are there with regards to the LH, you will have no pubertal development. So LHCG receptor defect, as we talk about, present to us with atypical genitalia, so very, very early and severe defect. FSH abnormalities will not have that much problem. You may actually have a high level of androgens, but the spermatogenesis may be defective. So just to put things in perspective, if you have abnormality in FSH, isolated abnormalities, you will have significant delayed puberty and primary amenorrhea. LH abnormalities may not cause that. Of course, GnRH and those problems will cause primary amenorrhea and delayed puberty. We will not focus that much on those groups today. Now, this estradiol is then converted from androstenedione via aromatase. So if you have a aromatase defect, you will have a sort of a situation in which androgens are high and estrogen are low. So the presentation in that scenario will typically be a child who has got some virilization at birth. Atypical genitalia will be there. The mother will also give you a history of hirsutism or virilization during pregnancy. And then things remain silent, and then later on they will present with estrogen deficiency in the form of delayed bone age and primary amenorrhea with delayed pubertal development. Of course, estradiol has to work on the estrogen receptor, and if there are estrogen receptor problem, you will again have problems which are associated with isolated abnormalities with regards. So if you have no estrogen action, the child will be born with a normal genitalia, because the default mode of development is a normal female. So zero estrogen action, normal female development will happen. Subsequent to that, the presentation will be delayed puberty, no breast development, and you will also have a problem in terms of amenorrhea. Now remember, because androgens are acting here, so your adrenal androgens are active, so therefore you will have a pubarchy which will happen in this scenario. So what I'm trying to do is to link up all this pathophysiology to clinical pointers which will help us reach a diagnosis in that perspective. Again, because estrogen is the major regulator of epiphyseal fusion, you will have a delayed bone age in that perspective. Of course, if you have a problem in the development of the uterus, particularly in the Mullerian structure, the upper 2/3 of the uterine, the vagina and the uterine development, you will have amenorrhea. These individuals will have normal breast development, normal pubic hair development, and they will have amenorrhea. So if you want to just assess clinically a girl who presents to you with primary amenorrhea, you have to look at three major things. What is the height? What is the breast development? What is the pubic hair development? And our algorithm will largely base upon this in that perspective. So abnormalities in the hypogonadotropic hypogonadism, that will be classical delayed puberty. Of course, you will have no development in that perspective. You may have pubarchy in this scenario because adrenal production is there. However, if you have a multiple pituitary hormone deficiency, you will also not have pubarchy. So pubic hair development is very important. Ovarian abnormalities like gonadal dysgenesis, the classical example being Turner syndrome with short stature, but many of the XY-DSD. So as discussed, XY-DSD is basically an act of omission, while XX-DSD is an act of commission. So something extra has to be done. So XY-DSD, any of the genes which are defective, they do not develop into testes. You will have a normal female development, which will happen. This will be associated with tall stature. As discussed, if you have a receptor problem, particularly the FSH receptor problem, you will have much more problems in terms of pubertal development. Abnormalities in aromatase will cause atypical genitalia at birth, followed by primary amenorrhea subsequently. If you have problem in the estrogen receptor, you will have pretty much a child who is a tall individual who has got reasonably high or an inappropriately normal level of estradiol. And then, of course, you have the structural defect. So primary amenorrhea can be because of a structural defect like a Mullerian abnormality or rarely imperforate hymen. That is something which is easy to identify but often missed. So if you have a young girl who presents to you with acute abdominal pain, and you find an abdominal lump, look at the breast development and ask whether there is a bleeding which has happened earlier or not. So this is a cryptomenorrhea, an easy diagnosis to make, but it is often missed. Otherwise, structural defects will have a normal breast development and a normal pubic hair development. Then if you have a functional defect, that means that you don't have a production of estrogen. You typically have either too little estrogen or too much androgen. If there is androgen excess, also you can have primary amenorrhea, and this can happen in the setting of PCOS and CAH, and you will have hirsutism. Then if you have an impaired estrogen effect where you will have no thelarchy because there is no estrogen in that perspective. This can be because of resistance, which is estrogen receptor defect, where your estrogen levels will be relatively high, or you have a hypogonadotropic hypogonadism, central cause, or you have a high FSH, which is a hypergonadotropic hypergonadism. High FSH can be because of a XX DSD or a XY DSD. Remember, XY DSD can also have a similar manifestation. If the testis is not developed, it's damaged, it's vanished, you may have a complete female appearance in that scenario. The characteristic feature here will be tall stature. So as I said, tall stature means you may have XY DSD, as I discussed about the first case in that scenario. An interesting scenario is complete androgen insensitivity syndrome, which may also present to you with a girl with primary amenorrhea who has got good breast development but sparse pubic hair. So again, breast and pubic hair will give you the diagnosis in most scenario. And finally, you can have a biosynthetic defect. So if there is a proximal biosynthetic defect like star or side chain cleavage, you may rarely have salt wasting, but you may also have non-classical forms in which they don't have salt wasting. 17-hydroxylase deficiency will have hypertension, and aromatase will have hyperandrogenism along with tall stature. So 4 groups of disorders which will cause tall stature include estrogen receptor defect, XY-DSD, aromatase, and all these scenarios you need to be wary about in terms of assessment and diagnosis in that regards. So the key questions that a physician who is managing a child with primary amenorrhea has to answer is it amenorrhea? If it's amenorrhea, it's structural or functional, and what's the cause? Now, amenorrhea is classically defined as no menarche within 5 years of onset of breast development, or by 15 years of age you do not have, you have to start evaluating and working. So don't do unnecessary workup if it is not required in that perspective. The next question is structural versus functional, and for this you have to look at the breast and the pubic hair development. So if all the components of pubertal development is there and you have amenorrhea, you may have a structural defect. Rarely this may happen in the setting of somebody who was doing well, then develops an acquired cause of hypogonadism. So you may have a scenario in which somebody develops a brain tumor, somebody develops hyperprolactinemia, but usually if you look at breast and pubic hair, you will get the diagnosis. So this scenario, there is pubic hair development, but there is no breast development. It means there is a GnRH deficiency. So you have no estrogen production, no breast development, but because adrenals are working, this is GnRH deficiency, the adenarche is normal. If you have no breast, no pubic hair development, this could be a constitutional delay of puberty and growth, or it could be an illness, or rarely a multiple pituitary hormone deficiency, where also you can have a similar scenario. If you have a normal breast development with sparse pubic hair, you are usually dealing with androgen insensitivity syndrome. And finally, if you have a normal breast development normal pubic hair development and amenorrhea, look for malformation, and that becomes relevant from that perspective. And these are very, very important in that regards. So if you want to differentiate now from a structural to a functional lesion, in a girl who has got thelarchy and pubarchy with a normal estradiol, it's usually a structural defect. Go for imaging, go for other aspects in that perspective. While if there is a thelarchy which is absent, pubarchy is variable, you have to think whether there is a hypogonadotropic hypogonadism in that regards. Now we know that this is a functional cause, not a structural cause. The next question is, what is the cause? So the key things to look at examination include hirsutism. If you have a girl who had a normal breast development, normal pubic hair development, but has significant hirsutism, think that this could be PCOS. We have seen so many PCOS with primary amenorrhea as well. So this is something to look at. If, however, there is no hirsutism and no thelarchy, it means there is a complete hypogonadotropic hypogonadism. In this regards, if they are tall, think of a XY DSD or a estrogen receptor defect. If they have a normal breast development and sparse pubic hair, that is androgen insensitivity syndrome. If there is salt wasting as discussed, star, hypertension, 17-hydroxylase and aromatase, again, hyperandrogenism and tall stature, which will be there. So if you understand and look at the basic clinical parameters, you will identify these causes. So these are the various causes I've summarized. We'll go into individual aspects which will help us reach the diagnosis. So most important is that usually, if somebody is not having periods, you expect the breast to be not there. But if there is a good breast development, you are dealing with either androgen insensitivity or hyperandrogenism or structural defect. Easy to identify in that regards. Pubarchy, if it's absent, you are dealing with androgen insensitivity, hypogonadotropic hypogonadism. Basically, if it is a very severe growth problem, especially because of a systemic illness or a multiple pituitary hormone deficiency. Hirsutism will indicate hyperandrogenism, and aromatase will also be a part of that differential. Now, very important, that's what the focus today is, height. Everybody who comes to you with delayed puberty should be short. We say everybody with precocious puberty should be tall. If you have a short girl, think thyroid. Similarly here, if you have delayed puberty with tall stature, there is something wrong going on. You have to think of androgen insensitivity. Usually you're thinking of a XY individual. So AIS will come there. Any other XY DSD will come there. And aromatase and ES1. So these are the 4 possible causes of tall stature with primary amenorrhea, and we will be covering all 4 of them. So this is just a hint as to what cases we're going to talk about today. FSH usually will be high in most cases. If you have a low FSH, you're dealing with a central cause basically. And of course, estrogen will also give you a picture. If your estrogen is high and you have amenorrhea, your diagnosis is there of estrogen receptor resistance. So if you look at the breast development, the pubic hair development, the height, the hirsutism, FSH, you will get the diagnosis in most cases in that regards. And finally, to put it in perspective, if your breast development is not there, you're mostly dealing with the hypo or hypergonadotropic hypogonadism. FSH is high, you have to work up for further. Estradiol is low, look for gonadal dysgenesis. Very important, do a karyotype. If estrogen is high, you will think of estradiol resistance. If you have got low FSH, you are dealing basically with a case of a problem of central cause, go for MRI. And if you have, on the other hand, a normal breast development and you have got no pubic hair, this is most likely androgen insensitivity, go for karyotype. If you have got good pubic hair development and hirsutism is there, work up for hyperandrogenism. No hirsutism, look for structural defect. The key message is no breast development, no periods, hypo or hypergonadotropic hypogonadism. Normal breast development without pubic hair, it is androgen insensitivity. Normal breast and pubic hair with hirsutism, PCOS. Normal breast and pubic hair without hirsutism, think of a structural defect. So Prasad is an endocrinologist who is working at DiaLife Center in Bangalore, and he has been actively involved with regards to various aspects of our initiatives. And over to you, Dr. Guru Prasad, to kindly start with this interesting case.
So thank you for those kind introduction. Am I audible?
Yes, yes, please go ahead. Yeah.
Good afternoon, everyone. This is the case of, again, a primary amenorrhea in a tall girl. And this case was, 28-year-old female who presented to us very recently with primary amenorrhea. And she was born out of non-consanguineous marriage. And she was fourth by birth order. And there is no family history or any history in her siblings of similar complaints or infertility. And she had a very significant past history. There's a history of surgery for bilateral inguinal hernia when she was 10 years old. And some specific questions were asked, and mainly there's no history of any virilization during puberty. And in fact, to see this case, in total, actually a diagnosis of Mayer-Rokitansky-Kuster-Hoster syndrome, that is Mullerian agenesis, was made all these years, because now she's 28 years and she had seen a lot of gynecologists because of primary amenorrhea. And every time she was undergoing ultrasound scanning, and the ultrasound reports used to come as absent uterus and intact ovaries. So with just a structural, diagnosis, they used to call her as MRK syndrome. But the worst part is that she was also told recently that, she can opt for oocyte extraction and IVF surrogacy, because in MRK syndrome, you will have intact ovaries, and always this is an option. And so she got married recently, and she's in fact sexually active too. But now, post-marriage, she approached, because she remembered that, the earlier gynecologist had told her that oocyte extraction is a possibility. So now she approached an infertility specialist for undergoing this procedure. And infertility specialist in turn referred her to us before planning for oocyte extraction. So on examination, all her vitals were normal. In particular, BP was normal. And again, she was tall for her in her family, and she had crossed her parents' height. She was measuring about 170 centimeters and weight of 66 kgs. And in pubertal staging, she had stage 4 breast with absent pubic hair and absent axillary hair. And systemic examination was normal, but except for a bilateral inguinal scar. So the investigation-wise,
Dr. Guru Prasad, if we stop here, you have got a girl. If you can go to that, back to the previous slide on examination. If we go back with our algorithm, you have a girl who has got stage 4 breast development and pubic hair, which is 1. So which means that the estrogen is there and working. So it cannot be estrogen receptor defect or aromatase deficiency, but the androgens are not working. So do you think it fits into with MRKH?
No, sir. In MRKH, you will have a normal, breasts as well as normal pubic hair. There won't be any ACTH or any other, problem.
So I think this is a very, very interesting fundamental thing on examination. Yeah. We had evaluated, if the people had treated earlier had evaluated carefully, as you did for the pubic hair, they could have immediately said, no, this does not look like MRKH. We have to think of something else. So as we discussed 4 causes of tall stature with primary amenorrhea, we already discussed 2 of them: aromatase deficiency, estrogen receptor defect. This again is interesting. Androgen insensitivity becomes an important cause of differential. And a tall girl also, that also is a big clue which is there. So it limits your differentials also. Please carry forward.
Yeah. So just by clinical examination wise, we are sure that we are not dealing with MRKH. So now let us see the investigations. The basic investigations again showed us the similar picture. Here again, we have an elevated LH level of 18.9, but FSH was normal. Then the TSH prolactin was normal. AMH was much elevated, more than 23. And both testosterone free and total were elevated with normal estrogen levels.
So why do you think, Dr. Guru Prasad, you have a discrepancy between LH and FSH?
Yeah, because, LH, gonadotropes do have androgen receptors. And we know that LH is regulated by negative feedback inhibition from the androgens. And these receptors are not functioning. So the androgens are not suppressing the LH. Whereas FSH, the regulation is by the negative feedback inhibition from the inulin levels, which will be normally acting in these people. So unlike in gonadal dysgenesis, where both will be elevated, this is one condition where we have LH elevation, but not FSH.
I think that's a very, very nicely you have put this out. And this is again, a very interesting biochemical finding. Somebody who has got a high testo, definitely for a female, it is high, but for a male also, it's on the high end of normal. And your LH is also high. So testo should suppress LH. There's no confusion about that. If high testo, high LH, it is an androgen insensitivity. I think that's a clear-cut clue. And FSH is normal because of your inhibin suppression. So this feedback and all these concepts play an important role. If you remember Dr. Shekhar's case, we had got a high LH and that was pushing the androstenedione and that was causing all that DSD and some clitoromegaly which happened in that regard. So I think clinical and this thing, your diagnosis is pretty clear here on that. And estrogen levels are also on the higher side because your testo is slightly high and you are aromatizing them into estrogen. Please carry forward, Dr. Prasad.
So the main investigation which we are waiting was a karyotype. And this makes the whole diagnosis very, very, very specific that we are not again dealing with MRKH. That is, karyotype wise, we got 46XY. So we are dealing with 46XY DSD. So MRI scan, unlike all other previous ultrasound scans, again showed that the patient was having bilateral ovaries visualized. So I can put it in a thing that it is a ovaries what they have mentioned. We are not sure whether they are really ovaries because the karyotype we have got is 46XY. So radiological wise, the features were suggestive of MRKH.
So if you look at the AMH levels, if you look at the testosterone levels, this cannot be an ovary. This has to be a testis, a functional testis. That's why you have a male range AMH. You've got a male range testo. So this is clearly, I think that's because they have found some gonad. So it's an intra-abdominal testis. That's what we can, I think, conclude from there. Yeah, please carry forward. Yeah.
So again, because of that radiological thing, we were concerned whether it is CAS and versus MRKH. But it was very clear from the beginning, from clinical examination, that we are not dealing with the MRKH. So if you see MRKH and CAS, karyotype is the main thing which differentiate this. In MRKH, it is 46XX, whereas in CAS, it is 46XY. And again, the pubic and axillary hair will be normal in MRKH, but will be absent or sparse in CAS. Again, the testosterone and the AMH levels, which is elevated in our case, again rules out MRKH. So now we are left with the 46XY with the normal female external genotype. So now, should we stop at CIS or should we see for something else? So what could be the other differentials in case of 46XY with normal female external genitalia? So we have four main DDs. One is the CIS. Second is the complete gonadal dysgenesis in 46XY, that is Swyer syndrome. It could be the distal part of androgen biosynthetic defects, because in the past history we never had any history suggestive of any crisis. So we are dealing with something distal part of the androgen biosynthetic defects. So if we see these four features, four pathological entities, now let us come to the Swyer syndrome. Could it be a Swyer syndrome? So what happens in Swyer syndrome? We have complete gonadal dysgenesis. So the dysgenetic gonads will not produce any gonadal steroids, including the AMH. So here we see Mullerian structures to be intact. So this is not there in our case. Again, Swyer syndrome, we are able to rule out with just one feature. Apart from that, secondary sexual characteristics also will be absent. But in CAIS, again, we have normal AMH, in fact, elevated AMH, and we won't see any of these Mullerian structures in spite of a normal female external genitalia. So this holds good in our case. So if you see, the second main thing is the secondary sexual characteristics in which breast development will be normal in these people, but absent or sparse pubic hair. Again, this is holding good in our case. And if you see the other two, that is 17 alpha and 17 beta HSD3 deficiency. So in 17 alpha, again, there won't be any Mullerian structures. There won't be any secondary sexual characteristics. But the important aspect in this, there will be elevated blood pressure. That is hypertension. Most of the times it will be seen, if not in all cases. So in 17 beta HSD3 deficiency, again, there won't be any Mullerian structures and secondary sexual characteristics will be absent. blood pressure will be normal. But one important clue, clinical clue, what we see in these patients, because our patient is already at 28 years, you could have seen this aspect, that is pubertal virilization. So what happens is that during puberty, these patients tend to have extraglandular conversion of androstenedione to the testosterone. So you could see this pubertal virilization, which was not there in our case. So now it's very clear, both biochemically, karyotype-wise, and clinically, that we are dealing with complete androgen insensitivity syndrome. So if we look into this aspect, some few lines on this pathological entity, that is the CAIS. It is X-linked recessive disorder with mutations in the androgen receptor gene. The prevalence estimates is almost 1 in 20,000 to 1 in 90,000 genetic males. So the presentation is quite different. When we see an infant with the CAS, the main presentation is with bilateral inguinal or labial swellings. So it has been advised that any infant with bilateral inguinal or labial swelling, we are supposed to check their karyotyping. Karyotyping is very mandatory in these cases. So when these patients present in adolescence, usually the presentation is in the form of primary amenorrhea. So as we know this, that the karyotype will be 46XY with a normal female external genitalia. So again, as we already stated, the increased AMH, there won't be any Mullerian structures, but the normal breast development because of the aromatization of excessive androgens. Again, sparse pubic hair, elevated testosterone levels and estrogen levels. And again, as we already discussed, elevated LH levels, but normal FSH levels. So I did some simple literature search to know what is the commonest gonadal location in these CIS patients. Out of the 1 or 2 cases that has been identified in the literature, in one series, they have seen almost 52% of these cases, the gonads are in the abdominal location. See, in another series, they said that almost 86% the location of gonads were in abdominal. And it is also seen in these case series that patients with these abdominal testes had aberrant pelvic ligaments extending from medially from the gonads. So now it makes us clear that whatever the MRI or the ultrasound features, if they said that could be a ovary or hydrosalpinx, which stated, could be, I think we are looking at abdominal testes with some medially extending pelvic ligaments. So now how to prove this? I think the main thing what we have to wait for genetic workup. That will tell us the clear cut. But still, again, we need not wait for this because we are 100% sure with a biochemical thing that we are dealing with androgen insensitivity syndrome. So what next for this patient? We are planning for an exploration and gonadectomy. And again, gonadectomy in these patients with CIS is quite controversial because the risk of germ cell tumors pre-pubertally is very, very mild. It's almost about 0.8 to 2%. So conventionally, it has been now seen that gonadectomy has to, we have to wait for gonadectomy till they cross the puberty because we need all these gonadal steroids for secondary sexual characteristics. So since our patient is at 28, and it's actually the high time that we have to plan for a gonadectomy in this patient. So post gonadectomy, we have to plan for a hormone replacement therapy. So the conventional hormone replacement therapy is with the estrogens, mainly to maintain the secondary sexual characteristics, bone and cardiovascular health, and also to promote general well-being and sexual function. And there is no role for progesterone because here we don't have any uterus here. So there is one more thinking that is coming up actually, whether these patients do better with androgen replacements. So there are few studies, mainly which I have quoted there. It's a very elegantly performed study which showed that when we replace them with the androgens, the psychological well-being and sexual functioning is far better when you compare with the patient who are taking, who are being given estrogen replacements. However, presently the conventional treatment would be estrogen replacement.
And when we are talking about androgens, what doses did they use, Dr. Guru Prasad?
I think they had used very high doses actually. They had quoted somewhere between 300 to 900 milligrams almost once in 2 weeks.
Yes.
That was, they had used it.
Yeah,
so they had seen a lot of adverse effects, in fact, in that group.
So I would be very cautious because even for partial AIS, we have to give very high doses. So
Yes.
this complete AIS will require huge amount of testosterone, and that will have many other effects. So we know that there are other receptors or a non-receptor effect, some membrane receptor, and all those things can cause a confusion. So this was a very, very interesting case, Dr. Guru Prasad. Thanks for presenting. And this case really looked into a case which was actually diagnosed as MRKH, and based upon the absent scenario, but then when examined was found to have no pubic hair development, and in fact was being evaluated by the infertility specialist for possibility of ovum pickup and then use in the form of a surrogacy in that perspective. So again gives a message that we need to have a careful clinical examination. Tall girl with primary amenorrhea, normal breast, no pubic hair development, think of a AIS as a possibility.